Hello everyone, I am Vaibhav Ramesh Naik. I am here going to present the morphology of three important pathological conditions like acute appendicitis, lobar pneumonia, and myocardial infraction. Acute appendicitis. Acute appendicitis is an acute inflammation of the vermiform appendix, usually caused by obstruction of its lumen, leading to bacterial infection and suppurative inflammation. Gross morphology of acute appendicitis. Serosa appears dull and congested. Fibrino-purulent exudate on serosal surface. Appendix swollen and congested. Lumen filled with pus. Gangrenous discoloration or perforation in severe cases. The diagram shows the specimen of acute appendicitis. Here we can see impacted concentration of serosal exudate which constrict the lumen, which leading to acute appendicitis. We'll see microscopy of acute appendicitis. Here we can see acute inflammatory infiltrate in neutrophils. Neutrophil extend into muscularis propria, which is essential diagnostic feature. Mucosal ulceration, edema and vascular congestion, suppurative necrosis in advanced region. Here in diagram we can see congested vessels, necrotic mucosa, and neutrophilic infiltration in muscularis. Now we'll see lobar pneumonia. What is lobar pneumonia? Lobar pneumonia is an acute bacterial infection of lung characterized by consolidation of large portion of lobe or an entire lobe due to intra-alveolar inflammatory exudate. Lobar pneumonia progresses through four classical stages. So let's see gross morphology of lobar pneumonia. Lobar pneumonia have congestion, red hepatization, gray hepatization, and resolution. Congestion is lung is heavy, boggy, and red vascular engorgement and intra-alveolar fluid with few neutrophils. In red hepatization, lobe is red, firm, and airless. Cut surface are dry, granular, and liver-like. In gray hepatization, lung become grayish brown to yellow, fibrino-suppurative exudate persists, RBC disintegrates. In resolution stage, exudate enzymatically digested, normal lung architecture is restored. And microscopic appearance of lobar pneumonia as congestion. In congestion, capillary engorgement, proteinaceous edema, fluid in alveoli, few neutrophils and many bacteria. In red hepatization stage, alveoli packed with neutrophils, RBCs, and fibrin threads. Here you can see the diagram in red hepatization stage. Here we can see RBCs, neutrophils, fibrin threads, damaged alveolar wall, and congested vessels. In gray hepatization stage, fibrino-purulent exudate, desegregated RBCs, and leukocyte persist and fibrin are present. In resolution stage of lobar pneumonia, macrophage clearance of exudate, re-aeration of alveoli is seen. Here we can see the diagram of gray hepatization of lobar pneumonia. Here we can see neutrophils, fibrins, and clear spaces and macrophages. This figure summarizes all the four stages and correlates the gross and microscopic findings. Now let us see about myocardial infraction. Myocardial infraction is the death or necrosis of cardiac muscles due to prolonged severe ischemia resulting from an imbalance between myocardial oxygen supply and demand. In vast majority of cases, it is caused by acute thrombosis superimposed on a disrupted, rupture or eroded atherosclerotic plaque in coronary artery. Now, let us see gross and microscopic changes with time after coronary artery occlusion. There is initially no visible change. Within few hours, coagulative necrosis begins. By 12 to 24 hours, Infraction shows dark mottling with neutrophilic infiltration. Between 3 and 7 days, macrophages remove dead tissue, making the heart soft and prone to rupture. Over next few weeks, granulation tissue develops and finally dense fibrous scars form after about 2 months. So this table shows the time, cross morphology and microscopy. In 0 to 30 minutes, no change, but in microscopy also no change. In 30 to 4 hours, no change in gross early coagulative necrosis and edema seen in microscopic. In 4 to 12 hours, occlusional dark mottling, coagulative necrosis begins, myocytes, eosinophilia and neutrophils infiltration. In 12 to 24 hours, dark mottling. In microscopy, ongoing coagulative necrosis, hypereosinophilia and contraction bands are seen. In 1 to 3 days, mottling with yellow tan center. In microscopically, extensive coagulative necrosis with neutrophilic infiltrate. In 3 to 7 days, hyperemic border and central yellow softening. Macrophages remove dead cells. In 7 to 10 days, maximally yellow and soft tissues are seen. In microscopically, well-developed granulation tissue is seen. In 0 to 14 days, red-gray depressed borders. Microscopically, granulation with neovascularization. 2 to 8 weeks, gray-white scar form border inward. Microscopically, increased collagen deposition. After 2 months of Infraction, grossly dense white scars are seen. Microscopically, dense collagenous scars are seen. This figure summarizes all 4 stages and correlate the gross and microscopic findings. So as I told before, this is the figure from textbook. In this table, in first week we can see grossly no change or pale TTC bar NBT test negative in infracted areas. Around 24 hours, cyanotic red purple area of hemorrhage, pale hyperemic border, center yellow and soft. In second week, grossly we can see red purple periphery. In third week, the same changes are continued. Around 4 to 6 week, thin grey white hard shrunken fibrous scars is seen. Now, when we see the microscopic change according to time, in first week, no change, stretching and waviness of fibers are seen. Coagulative necrosis begins, neutrophilic infiltration begins, edema and hemorrhages present. Around 24 hours, coagulative necrosis complete, neutrophilic infiltration well developed. Around 48 to 72 hours, neutrophils are necrosed and gradually disappears beginning of resorption of necrosed fibers by macrophages, onset of fibrovascular response. In second week, around 10th day, most of the necrosed muscle in a small infracted are removed. Fibrovascular reaction more prominent. Pigmented macrophages, eosinophils, lymphocytes, plasma cells present. Around 40th day, necrosed muscle mostly removed. Neutrophils disappear. Fibrocollagenic tissue at the periphery. Around third week, necrosed muscle fiber from the large infraction removed. More ingrowth of fibrocollagenic tissue. Around 4th to 6th week, increased fibrocollagenic tissue, decreased vascularity, fewer pigmented macrophages, lymphocytes, and plasma cells. Now, you're going to see gross of myocardial infraction. Here we can see greyish white fibrous scar tissue has replaced myocardium, indicating a healed infarct. The myocardium is also thin here. This specimen shows a healed myocardial infarction with grey-white fibrous scar replacing the necrotic myocardium. These are the photomicrographs demonstrate the sequential microscopic changes from coagulating necrosis to inflammation to macrophage infiltration, granulation tissue formation, and finally fibrosis. In conclusion, morphology helps us understand disease progression and correlates clinical findings with pathological changes. Recognizing both gross and microscopic features is essential for diagnosis and management. Thank you.